registries, if you don't know who you're dealing with, we got a problem. As you move and try to integrate across systems, we've clearly got to know who we're dealing with. We have to know who can access what parts of the system and what they can do with it. That's pretty simple stuff. Diagnostic imaging, Ontario's great. All the hospitals in Ontario are now filmless, and the politicians do like to say Ontario's filmless. They don't know what an independent health facility is or a community clinic, so we've got to break that to them, and we've got to do something about that. I hope I didn't say something to offend the ministry and they're phoning to stop me. You never know. But DI, huge area there's already lots of benefits. We've got to keep it going. And then portal services. The only reason I want to talk about portal just a little bit is because it's a very different approach. If you do use Google or Yahoo or somebody's portal, one, there are two things that make a portal different than a website. I do lots of education with politicians on this as well. It's a portal because you've got to sign in. There's an authentication process. We've got to make sure there's a consistent one across the board. And also because you put the information you want on it. If you don't have diabetes, then you don't want all the diabetes information. If your child has asthma, you want the asthma information. You customize it for yourself, and that's the same if you're a provider or a person. That's the approach we use for a lot of these things. And eHealth Ontario, by the way, has a portal. So do lots of other people. I'm not sure what the footprint is in the Southeast Lynn. Lots of groups have portals. That's wonderful. We're not trying to build one and take everybody's business away. Portals, important things. By the way, I think the Ottawa area, they've got their big portal. You know what the number one thing that's accessed on their portal is each day? The cafeteria menu. And that's not a bad thing. That's a good thing because it draws people in and they use it, and then you can get into some of the clinical tools and start to move forward. And that's actually a good thing. Diabetes registry is on schedule. It's going to happen really fast. That's the other advantage of the portal. You can implement things very quickly because you put it up on the portal and you then put it on other people's portals who've got a similar framework as well, and you've got to develop the online education. That's for providers and it's also for people. And quite often as well, people will say that the people who are patients and their families in the province of Ontario don't have the knowledge to understand their own personal health information. I'm sorry. If you're a diabetic or a person with diabetes, I always use the wrong term. Person with diabetes, I think you can figure out your blood sugar. Those are the kinds of things. Clearly, though, there is some health information that you want an expert to help you understand. So you got to work out lots of rules around that. But for example, my dad has heart valve replacement, so he's on a blood thinner. He gets his own number from the lab now. He talks to his physician about once every 2 weeks, and they make a change or they do a plan. He tracks that himself now and knows, I need to call the doctor based on that. He gives some education to people and their families, and that's important, by the way, the people and their families, because quite often the person who has the problem isn't the most responsible person in the family. There's going to be lots of people in their families. We have to facilitate that and move forward. And those are the kinds of things that are going to happen and are going to enable this to actually get moving more quickly. I don't want to talk too much more about that. So I'll put up this one. I'm almost finished. I'm sure you can't read it. It's in the material. You can have a look at it. I'm not sure that it's in this book because it's out of the blueprint. But it's really talking about local data sharing within a single enterprise. That's what we've got now in a lot of places, and we've done a really good job on it, and we've invested a lot of money. So if you're from Kingston General, you can probably get lots of information from within your system. And I'm not sure if you could link to Hotel View. You didn't used to be able to, but Paul's had a good influence along with many other people. I'm sure you can now do that. But we're starting to do a much better job of that. People can get in there and access it. There's limited public access as well. But we're now moving into the second layer, which is point-to-point. So we actually have discharge summary, actually. Somehow, we've listened to the people in the system and the providers who said, I'd really like to, one, know when my patients go into the hospital and find out what the heck is up when they come out. And there are, I don't know how many projects doing that in Ontario. They're actually all now moving towards using the same standard of information. We're not actually doing much of anything on discharge summary except creating that standard and saying, knock yourselves out. But what we're really trying to get to with the electronic health record is system-wide sharing. It's a network model. Information goes both ways. People have defined roles. And for the role that you're using at that particular time, you've got a set of information you can access. That's how an EHR gets implemented. An EHR is a virtual concept. So, if you're a podiatrist, you don't get the same view the cardiac surgeon or the nurse in the acute care setting gets. There's a view for you and access for you. And one of the things that's important is people have to know who's accessed their information and be able to audit that. And, if you are a systems design person out there, that takes a little bit of a wrapper. Building the system to share the information is one thing. Putting the audit of all that around it makes it a lot bigger. I know you can't see this either. This is very, very similar to the InfoWay architecture for their electronic health record, which they don't deliver, by the way. They're supposed to help us accelerate our delivery. This is Ontario's electronic health record logical model. The reason that I show it is because it's pretty damn complicated. That's all right. We're starting to work at it. And, it's like you take one bite and you chew that and you swallow, and hopefully you don't need any medical care around that, and then you take another bite and you keep moving forward. And the reason that there's some violet stuff in there is everything that's violet is stuff that the $1 billion is already working on. And it's not just the $1 billion, because there's lots of local investment on that. Hospitals in Ontario still spend $500 million a year on e-health and health information technology, and do every year. And with the economy that might shrink a little, but it's not going to go to zero. So there's lots of investment, and that's why things like the integration layer and the portal access layer are so important, because then it allows us to integrate information and build on that investment that's all over the place. And there are some areas, can't see it, but over on the far side, health system management, information and research. There's almost nothing happening from an e-health perspective on that. And we've got to enable that. That's things like secondary use of data. Well, I think we need to work out the primary use of the data first before we get too far down that path. But if you have a look at this, when you get to presentation, you'll see we're well into those big provincial repositories. You don't want to do everything centrally, but there are some things like labs and drugs that it makes sense to pull in from a central perspective, because they're going to be accessed all over the place, and in reality, they're fairly simple pieces of information. Diagnostic imaging, you don't want to do centrally, and that's usually just because the images are so big that you don't want to move them around too much. We certainly can, but the other thing is diagnostic imaging referral patterns aren't provincial, they're regional. So we're going to have regional repositories for that. And then there are things like physician EMR systems that are going to be completely distributed. They're going to be all over the place. Physicians don't want their information shared centrally very much, unless they know about it. And who does? I don't want my banking information moving around too much either. I want it to be controlled. I want to share the right pieces at the right time. So anyone who says it's either all provincial or it's all distributed, it's a hybrid of all those things, like the banking system is. And I think this is the last slide. Have a look at the stuff. You can always send me questions. I've got a little bit of time to ask questions. I'll follow Paul, please, now. And thanks very much for having me here.